Great to be here. It's great to see everyone converging from all over the place. Really a terrific couple of days in store for us. And I've been charged with the unenviable task of trying in 15 minutes or so to comment, at least to lay some foundation, hopefully, for a discussion around precision medicine, which, of course, in the context of MS, is really predicated at its core on the notion that it's not a one-size-fits-all. There is heterogeneity. There are all multiple modalities where heterogeneity plays out in the context of MS. The clinical course, of course, the biology, treatment response, people respond differently to living with a chronic illness. There's impact on multiple dimensions in life, quality of life, vocation, play, and work. I will be focusing on the biology here to illustrate some of the principles, but one should keep in mind that the heterogeneity is really involves many domains of a person's experience with this condition over their lifespan. And our goal, of course, is to stop for this presentation MS across its domains and in each individual person. And the principles, although I'll be talking about the Stop MS context in particular, I think certainly translate across the restore and to some extent also the prevent dimensions of the pathways. So the focus here is on the biology, as I noted, and it's important also to recognize that while dealing with heterogeneity, there are some emerging themes in our field that reflect a sense of commonalities as well. And the notion of precision medicine, which referred to in the past as either individualized or personalized medicine, the NIH decided to call it precision medicine with a view that it isn't really a different approach to every single individual, but it's a more precise approach as opposed to a one-size-fits-all, and hence precision as opposed to individualized. But we do want to try to bring it to the level of the individual and then figure out whether there are common themes across groups of individuals to tailor treatment, because for 1,000 patients, we're unlikely to have 1,000 different immune-modulating therapies, as an example. And so just to revisit the clinical spectrum of MS very, very briefly, you're all familiar with this kind of cartoon that depicts the clinical course of what had been described clinically as relapsing onset and secondary progressive versus primary progressive. And it's important, of course, as we understand, that much of MS across the spectrum is subclinical, injury occurring under the surface that we need to figure out how to stop, and that there is a trajectory of the non-relapsing progressive disease that starts well before we appreciate it clinically. Similarly, that trajectory is present in primary progressive MS, and even more interestingly, we now appreciate that as part of the subclinical aspect of patients who clinically appear to have only progressive onset MS, there is a biology underneath, it's a little hard to see there, that is representing a similar relapse biology underlying the surface. So in fact, the difference perhaps in the spectrum is more a question of what is or is not visible clinically, as opposed to different biologies across PPMS versus RR SPMS. And so we recognize that there are these two biologies that we want to understand and impact to stop MS. One, the relapse biology, and the other, the non-relapse progressive biology, which exists across the spectrum. But there is heterogeneity. And this is a simple immune pathophysiology cartoon that tries to capture the principles that we're dealing in the periphery with immune cells that interact with one another, get activated, and then through a cascade of molecular interactions are able to invade into tissues, the CNS in the context of MS, of course. And we used to think of it as a T-cell mediated disease. I think all of us now appreciate that it is about immune cells of different types interacting with one another and shaping each other's responses, with a view again that the peripheral cellular immune interactions are relevant for triggering relapse biology, and that CNS compartmentalized mechanisms, including compartmentalized inflammation as well as degeneration, and I'm sure we'll hear more about those later in this meeting, are driving or contributing to the non-relapsing progressive disease. And there's heterogeneity across these different mechanisms in the different compartments. I'll use this study that happens to be in a pediatric context just to illustrate a principle of why people may differ at the level of a fundamental biological mechanism. So this is a study in children with either multiple sclerosis or other CNS inflammatory conditions like MOG-associated disease and healthy controls. And we asked on one hand, with respect to potential bad guy cells of the immune system on the effector limb side, and could identify this average abnormality in a particular subset of CD8 T cells. And the details are not as important, but to recognize on one hand, this is a statistically significant average difference, but it's very much overlapping with many of the controls. So this is, of course, not a diagnostic test, and there's a range. If you look at the same time in the same individuals, not just at the effector limb, but at the regulatory limb, this data set describes what happens when you use putative regulatory T cells to see if they can suppress proliferation of responder cells. And the maroon colors are the MS patient trajectories. The pediatric MS individuals have Tregs that are less capable of regulating. But again, with a lot of overlap in terms of the range of the Treg capacity. The advantage of looking at both limbs at the same time is you can ask about how they relate to one another in an individual. And when you look at the simple ratio in this data set, you get a sense that you're pulling out the differences. And so what this tells us, and I think it's an important principle, is that MS may manifest, or disease activity may manifest, either because there's an insufficient Treg problem that is big enough to have disease, or an effector problem that is big enough, but also lesser combinations of both that in combination are sufficient to have disease or disease activity. And people differ in the relative contributions in all of the gene-environment interactions that we learn about that shape each aspect of these responses. So again, here, described at the level of T cells, we now have techniques that I think will play into a better future of personalized or precision medicine, which are able to look in a more granular fashion, if you like, at the various aspects of the immune response and its complexity. This is just going to make the point that there's a great range of normal for us to consider when we think about the balance between effectors and regulators of the immune system. And so you can imagine across the bottom a range of regulatory capacities, across on the y-axis a range of effector capacities, and the green represents a broad range of normal, where the balance is such that normal autoimmunity is maintained without spilling over into autoimmune disease. But if you have too much effector and insufficient regulation, as I mentioned, you may have an autoimmune condition like MS. If you have too much regulation relative to your effectors, you may have infection or cancer. And we know that this paradigm is true because the checkpoint inhibitors that you'd heard about are associated with a non-trivial frequency of people developing a secondary autoimmune disease. So the immune system is all about checks and balances, and people differ. And the more granular look with some of the emerging techniques, this just happens to be another data set looking at subsets of T cells, particularly here CD4 T cells, and comparing across individuals with MS and MOGAD. So on one hand, this site-seek approach, which allows us to profile immune cells in a pretty granular way, can identify differences across diseases, which is an important insight into disease mechanisms, but also you'll appreciate within each disease, each column representing an individual, there's variability. So people differ within the disease state, not just across diseases. And if I highlighted the importance of the balance between different T cell subsets in regulating normal autoimmunity, we know that these cells don't work in isolation. There are antigen-presenting cells, including myeloid cells. They talk back and forth. We know that B cells come in different functional response flavors. They're also involved directly in regulating autoimmunity, and they can talk back and forth with the other cell types. So the complexity is that the checks and balances exist for each of these cell types and their subsets and their interactions. And people are going to differ in this regard in ways that may invite us to think differently about their management and their course. The illustration here of how a multi-hit model can influence a person's susceptibility to disease or disease activity makes the point that if you consider a person, for example here, who on the left-hand side has a Treg balance that is sort of in the upper range normal. In the middle, myeloid cells are perfectly normal, but there's a major abnormality in the B cells, and this is enough in combination to contribute to this person's autoimmune disease, such as MS. And importantly, and we talked about the importance of comparing and understanding across neurological diseases, but also across autoimmune diseases, I think there's an important opportunity. We're not, of course, the only field interested in precision medicine, and instead of thinking in a more siloed way across MS, for instance, type 1 diabetes, inflammatory bowel disease, in each of these conditions, these cell types and their subsets are implicated. Perhaps we should be thinking across in this fashion, which I think is going to be playing out very importantly in terms of therapeutic development. So what I emphasized until this point really relates to the relapse biology, but to make again the point that within the central nervous system, the compartmentalized inflammation is made of cells of the immune system and the brain, and they too have different experiences and different response propensities across individuals, relevant not just to the injury, but also to the potential for repair. And this is now looking at the age span context where Hans Lassmann's cartoon, which makes the point that the transition within an individual from a more predominant peripheral inflammatory to CNS inflammatory and degenerative across the experience is something that we need to take into account, because we can assess and try to understand what the precise approach is for an individual at some point in their illness, but that may well change over time. The question is, what can we do in terms of repeat measurements across the age span? We deal with immune senescence on one hand, but also inflammaging, and I won't go through the details here, but these processes play out in all individuals normally and contribute to a variety of diseases. And when we think about a condition like MS and its heterogeneity, it's important to realize that we're superimposing a condition on top of a normal host. But the range of normal is huge, if you think just the example of vaccine responses, the same exact vaccine can produce a 3 log-fold range of responses in a healthy population. So people differ very importantly and impressively in terms of their immune response propensities. These different processes contribute on one hand to increased cancer and infection with age, but also to an increase in autoimmunity, chronic disease, and comorbidities that play out differently across individuals, with a lot of important implications, for example, with respect to disease-modifying therapy, when to continue, what to continue with or stop, and so on. And finally, just layering in also the issue of sexual dimorphism, which was brought up earlier by Caroline, and this is very interestingly playing out differently over the age span. So there are differences between sexes from an immune response propensity standpoint, and there's a different trajectory of the evolution of these over time. So how do we approach this? We have to, I think, embrace this heterogeneity, as complex as it is. And if you think of a multimodal assessment, we try to incorporate it in various initiatives moving forward that I think we will have a chance to elaborate on in the discussion, a variety of clinical and paraclinical measures, a variety of biological measures, including relatively simple ones that can be assessed in serum. The complexity that I introduced was really just to set the stage for discussion. We have to be pragmatic about what we can actually apply across large populations in an accessible way. And of course, multiple different imaging modalities that together contribute to a better overview of a person's experience with multiple sclerosis. And to illustrate that here, the promise, if you like, of precision medicine is to really transform the care from another N of 1, where we're not quite sure what to do, to trying to think in a more precise way of how such an individual may fit in to our accumulating knowledge. So if you think of putting people in a sort of simplified two-dimensional UMAP, and you have 10 individuals that look entirely different, 50 will still look more or less like random scatter, but when you get to numbers, you start seeing a coalescence of some of these, some groupings, and these may reflect, for instance, more severe, less severe disease trajectories, better or lesser response to a particular therapy. And so a new person comes in, and we apply the precision medicine platform to them, and then it turns out that they fit into one of these particular groupings of individuals, allowing for us to deliver more precise medicine. So hopefully this is a little bit of a backdrop for our discussion, and I'll stop here and thank you for your attention.